In this video lecture, we will be covering chapters 17 and 18. Chapter 17 is about altered nutrition. So nutrition can be defined as the process of ingestion and utilization of the nutrients for energy. And energy is the capacity or the ability to work, and through this metabolism in our cells, in our body, we produce ATP that it is necessary for producing work, and also we produce heat, and some of our cells, the excitable cells like the neurons, will through this process of nutrition will be able to conduct action potential or impulses that are going to control many of our organ systems in our body. And also with this energy that we obtain through these nutrients that we ingest, we have the ability also to contract our muscles. Now, the nutrients are subdivided into different categories. So one is water, and also we have macronutrients, which will be the nutrients that we require in large amounts, like proteins, carbohydrates, and lipids. And we have micronutrients, which are the ones that are required in small amounts, like vitamins and minerals. Water is the largest component of our body, making up like 60% of the total body weight in males and 50% in females. And water is necessary because with water we have several functions in our body working, like digestion, absorption, etc. So some of the functions of our of the water in our body will be to act as a solvent for many molecules, including electrolytes like sodium, potassium. It also helps to maintain fluid balance between the extracellular and the intracellular space, and it also helps to transport nutrients and waste products through the bloodstream, and it helps to lubricate many structures in our body, keeps them moist, and also it will help to regulate the body temperature. And it will be the foundation for many metabolic reactions, and it will be contributing to the structure of cells and the circulatory system. About the proteins. The proteins is the major macronutrient in our body, because with these proteins we can have this structure in our cells, like our muscle cells that are made out of several proteins like actin, myosin. So we can have a specific shape and in a specific function through these structural proteins. But the proteins also makes functional structures like enzymes. Most of our enzymes are made out of proteins, and with these enzymes we have these metabolic reactions going on in our body. Now, the proteins are made out of 20 different amino acids. 9 amino acids we don't produce them in our body, so these are essential, so they have to be consumed within our diet. And the other 11 we ingest them, and then we can interconvert some of them through chemical reactions like transamination reactions, etc. So we can have these different 11 amino acids, just in case that we haven't ingested one of the 11. But the 9 essential ones, we definitely need to have them in our body. Now, when we ingest our proteins, we start digesting them in the stomach through this pepsin, which is an enzyme that it is produced in the stomach, and these proteins we convert them into polypeptides, and then these polypeptides will be transferred with the chyme into the duodenum, and in the duodenum we'll have the emptying of the pancreatic proteases through this ampulla of Barré, or this sphincter of Oddi here within the second portion of the duodenum, and then the trypsin, chymotrypsin, and carboxypeptidases, which are proteases of the pancreas, will start breaking down these polypeptides into tripeptides, the peptides, and amino acids, which are smaller units of the proteins. And within the small intestine, we have brush border enzymes that helps to break down these tripeptides and the peptides into the peptides and amino acids, and then we have dipeptidases that can break down these dipeptides into amino acids, and then they can be absorbed. Now the lipids. So the lipids are these components of our diet that are made of long chains of carbons, and some of them, they are classified as triglycerides. And when you ingest these triglycerides can be broken down into smaller components like fatty acids and glycerol. Now the compound lipids are phospholipids, lipoproteins, and glycolipids that forms these plasma membranes within our cells, but these will be coupled with other type of lipids in our body like cholesterol that makes this plasma membrane to be a little bit rigid. Now the bile salts will be also part of the esterols, and this will help us to emulsify the fats so we can absorb these fats, and then we can utilize them as a source of energy. So one of the functions of the lipids will be to provide a rich source of energy, and we store these lipids as adipose tissue or fat, and then through this fat we have support of different organs, so we have cushioning of different organs, and we also insulate the underlying tissues in our body and give us some thermal protection up to a certain point. And also it helps to facilitate certain processes in our body, and when we ingest lipids, we start digesting these lipids through the oral cavity, so we have lingual lipase there that start breaking down some of our fats, and then from there the lipids will pass into the stomach where we have gastric lipase, and from the stomach the food will be entering into the duodenum, and in the duodenum the gallbladder will release the bile so we can start emulsifying the fats and breaking them down into smaller globules. So we have large globules of fat coming from the stomach, we emulsify them with bile in the duodenum, and then we start making these small globulets of fat that will be broken down by the pancreatic lipases that are also emptying into the second portion of the duodenum, and then from there we will start absorbing these byproducts of the digestion of triglycerides, which will be monoglycerides, fatty acids, and glycerol, and then we can bring them into the circulatory system and also into the different cells, so that the cells can utilize these fats, or if the cells they don't utilize these fats, the adipocytes within our body will be storing these triglycerides for further use whenever we need them. Carbohydrates, it's another micromolecule that we ingest in our diet, and these carbohydrates can be subclassified into monosaccharides like glucose and fructose, or oligosaccharides like sucrose and lactose, and complex carbohydrates like polysaccharides, which are starches and fibers. So these are the dietary carbohydrates that we can ingest. Functions of the carbohydrates is to provide energy, and actually our body, when it comes to getting energy from macronutrients, it prefers carbohydrates because the chemical structure of the carbohydrates It's very simple and it's very easy to be broken down by the enzymes of the glycolytic cycle, and it's much easier than for our body to obtain energy from the carbohydrates. Now, some carbohydrates, they can reduce the levels of cholesterol, like in the case of dietary fiber, and as well, dietary fiber can aid in the gastric motility because this fiber is not absorbed by our body because we don't have the enzymes to break down this dietary fiber, but we will produce a bulk within the intestinal lumen so that it will absorb water, and it will help to bring down the different nutrients from proximal areas of the digestive tract into distal areas, helping in gastric motility. Carbohydrates are starting to be digested within the mouth as well, within the oral cavity, similarly as to lipids. So we have there salivary amylase that start breaking down starches. Okay, and then these carbohydrates, once they pass into the stomach, they will be churned together with the different nutrients that we have ingested, and then they pass into the second portion of the duodenum, and then we will release pancreatic amylase. So we can have more breaking down of these carbohydrates within the second portion of the duodenum. From there, the carbohydrates will pass into the rest of the different regions of the small intestine, and we will use several enzymes that start breaking down the different types of carbohydrates that we might have ingested. Like if someone has ingested maltose, we have maltase enzyme that it will break down this maltose into glucose monomers. And then if someone has ingested like sugar or sucrose, this sucrose, which has fructose and glucose, will be broken down by sucrase enzyme into these corresponding monomers. Monomers are basically the simple basic units of macromolecules. Okay, so in the case of lactose, the sugar that it is found in dairy products, or milk, the lactase enzyme will start breaking down this lactose into glucose and galactose. And then in the brush border or the apical side of the enterocytes, we have these enzymes that are going to start breaking down these monosaccharides, and it start bringing down into the circulation. So we have then the absorption of glucose, fructose, and galactose within these intestinal cells, and from there it goes into the circulatory system to be processed by the liver and to be stored as glycogen within the liver, within the muscle cells as well, be stored as glycogen, and whatever is left after you have deposited glycogen into the liver and into the muscle cells, whatever is left is going to go into the adipocytes to be stored as fat. So our body basically will not waste nutrients. It will always store them just in case that you fast and you need these energy molecules, so you start breaking them down so you can have energy. Now, in terms of the micronutrients, so we have vitamins, which are classified as micronutrients. The vitamins are organic substances, and these organic substances are necessary for several structures to be made. So we have major classification of the vitamins. We have fat-soluble vitamins like the ADEC group, vitamins A, D, E, and K. And we have water-soluble like the group B vitamins and C. And these vitamins will be necessary then for the metabolism of micronutrients, and it will help also to develop genetic materials, hormones, collagen, and to help the nervous system to function properly. The name of vitamin B1 is riboflavin, vitamin B2 is niacin, vitamin B6 is pyridoxine, and vitamin B12 will be called cyanocobalamin. Minerals are micronutrients that are inorganic substances. And these minerals, although they are necessary in very small amounts, they are very, very critical for several cellular processes. So within these minerals, we have what we call macrominerals and microminerals. So the macrominerals are sodium, potassium, calcium, phosphorus, magnesium, and sulfur because they are necessary in greater amounts than the macrominerals: iron, zinc, fluoride, copper, cobalt, etc. Functions of some of these minerals are in forming bone, like in the case of calcium, forming hemoglobin in the case of iron, forming cofactors of enzymes, like in the case of zinc, calcium, copper. Uh, they also help in the formation of hormones. They are part of chemical mediators, and they help to mediate transfer of action potentials, like in the case of calcium. If you remember from your AMP1 class, during the action potential, when the action potential reaches the synaptic terminals, calcium enters into these synaptic terminals, and then you release acetylcholine. So then you can transfer this acetylcholine into the postsynaptic cell. So then you can have this depolarization of the postsynaptic cell. And also these minerals are necessary for the maintenance of the acid-base balance. In the case of these sodium potassium pumps, they help to regulate the functioning of the cells and also the maintenance of the acid-base balance. Within these nutrients, we have the RDAs, or recommended daily allowances, that are the minimal amounts of nutrients that someone can ingest according to the different characteristics of this person. So we have these RDAs then with the recommendations based on age, gender, activity level, current weight, physiological condition, like if a female is pregnant or if it's lactating, and the macronutrients can be recommended in amounts of micrograms or milligrams per day, and also can be recommended in percentage. So out of our carbohydrates, we're supposed to have an intake of between 45 to 65% of all the nutrients. And the macronutrients, of course, the proteins will be between 10 to 35%. And for fats will be between 20 to 35%. So maintenance of our body weight and composition will require balance of energy intake and expenditure. And the intake is most of the time regulated by numerous factors, including the input from the hypothalamus. So in the hypothalamus, we have the center for appetite or for hunger. And also we have this activity within the digestive tract, that it is regulated by the vagus nerve. And also we have this society or feeling of fullness that it is influenced by hormones, like in the case of leptin hormone. Leptin is a hormone that it is secreted by the adipocytes. And when you have enough leptin in your body, you have a feeling of fullness or satiety, so you will stop eating. And one of the things about leptin that it is important is that we tend to secrete leptin when we are asleep. So if you have a good night's sleep, you're supposed to secrete enough amount of leptin, and that will give you the sensation of satiety, and it helps you to control appetite. Now, along with that, we have other factors like food availability, emotional and physical health, uh, and whenever then we have intake these nutrients, and then we use how many nutrients we needed, we then can store the nutrients in the adipocytes as lipids, and we also can store micronutrients like vitamins A, B, D, and E and K in the liver. Also, we can store iron, copper, and glycogen. And then when times of need comes, and if you haven't ingested any of these vitamins, or if you haven't ingested glucose, your or food in general, your liver will release this glycogen and then these vitamins. So here is the diagram showing you some of these long-term signals that regulates food intake and energy homeostasis. So insulin and leptin are very important for long-term regulating the intake of food and energy balance. And both of them act on the central nervous system to inhibit food intake and to increase energy expenditure. And most likely they will be also coupled together with the activity of the sympathetic nervous system to control this energy expenditure and energy balance. Now, the digestive system is essential for digesting and extracting these macronutrients, absorbing also these nutrients, and forming a physiological and chemical barrier against microorganisms and other foreign substances that can be introduced during food ingestion. So, this digestion is in the process by which food is broken down mechanically and chemically, and it will be happening, of course, within the gastrointestinal tract, and it will be converted into absorbable components. So this figure highlights these different portions of the digestive system that help us to uh, perform digestion. So everything, as we know, starts in the mouth and end in the anus. So digestion process is long, and it will have different stages, and it will start breaking down these nutrients and absorbing them so we can obtain energy out of them. One of the process of digestion will be, of course, absorption, and then within the absorption process we will use different enzymes that are specific for breaking down these macromolecules into small units or monomers, so we can have the nutrients going into our body. So for instance, in the pancreas we have these lipases that will convert fats into monoglycerides, glycerol, and fatty acids, and then the rest of the nutrients will be absorbed in the digestive system, in the digestive tract, in the intestinal cells. Now for the altered nutrition. So in this case, you have a problem inadequate of or excessive exposure to nutrients that will lead to different signs and symptoms. So altered nutrition or malnutrition is a state of inadequate or excessive exposure to the nutrients. And this exposure can include intake, digestion, absorption, or metabolism of nutrients. And some of the causes for altered nutrition will be genetics that impact the metabolism or absorption of the nutrients, will be damage to the gastrointestinal mucosa, or it can also be a problem of inadequate or excessive intake of food or that require specific nutrients. And it can be also losses of nutrients, excessive losses through vomiting, diarrhea, the use of laxatives, or someone can have a hypermetabolic state. In the case of someone, for instance, having hyperthyroidism, having cancer, the person might have a severe infection, fever, or the person might have also malabsorptive syndromes because the person doesn't have the specific enzymes. Some people born with a genetic defect that prevents them from having some enzymes, and then the person won't be able to absorb certain nutrients. Also, the person might be exposed to unsanitary food or water, and in this case, this will cause an inflammation of the digestive tract that prevents the absorption of nutrients. So this is the concept map of some of the problems of altered nutrition. Overnutrition can be caused by, of course, overingesting nutrients, so that can lead to obesity. The person, if it overingesting certain vitamins or minerals, can have this specific toxicity. If the person has undernutrition, like inadequate intake, the person will have deficiency of certain micronutrients or micronutrients. Also, as well, will be the same for altered digestion or malabsorption. In altered metabolism, the person can have genetic defects that impair them from absorbing certain amino acids, like in the case of phenylketonuria, and the person can accumulate toxic metabolic byproducts for the absence of absorption of certain amino acids. Also, the person can have defects in lysosomal storage, like Tay-Sachs disease. So for inherited metabolic disorders, so these are often referred as errors in amino acid and lipid metabolism, and these are usually genetically based problems in which the person doesn't have an enzyme. Examples again will be phenylketonuria, in which the person will have accumulation of byproducts of phenylalanine that will be toxic to the brain. In undernutrition, so the person might not have enough uh, consumption of nutrients that will lead to the lack of calories, and the person will have as well inadequate intake of vitamins and minerals, and as well the person can have problems like absence of the digestion, absorption, and distribution of nutrients within the body. That, of course, everything can result in the lack of nutrients that will stimulate the growth of muscles, and in general, it will lead to muscle wasting and weight loss. Examples will be marasmus and kwashiorkor. In marasmus, you have this lack of nutrients, like the lack of all nutrients. In the case of kwashiorkor, you have the deprivation of specifically proteins. And this will lead to an imbalance of proteins in the case of kwashiorkor that is going to lead to the absence of repair, healing, and fluid imbalance. So in kwashiorkor, the continued intake of carbohydrates will stimulate the insulin production and is going to lead to the glucose uptake of energy. However, the person won't have enough proteins, and this will be the inability to synthesize new proteins within the body, and this is going to lead to severe edema. So in this case, the person who suffers from kwashiorkor is going to have this fluid going into the abdomen, so the person is going to have protuberant abdomen, and the liver is going to enlarge, and the person is going to have weak abdominal muscles, and of course is going to have hypoalbuminemia. In overnutrition, you have the state of excessive exposure to nutrients, and the person will have excessive calories or toxic levels of vitamins and minerals. In malabsorption, you have lack of movement of specific nutrients across the gastrointestinal mucosa, and this malabsorption can affect one nutrient such as lactose or vitamin B12, or it can affect all the nutrients. And if that happens, you will have something that is called malabsorption syndrome, in which several of the nutrients are not adequately absorbed. So in the case of fat are almost always included in the malabsorption uh, syndrome. And some of the causes will be problems with the processing of or digesting of the nutrients, like in the case of pancreatic dysfunction, you have enzyme deficiencies. Like if someone has pancreatitis, he won't be able to secrete these proteases, these lipases, or possibly the person, in the case of someone who had, for instance, the gallbladder removed, the person won't be able to secrete this bile to emulsify the fats, and then these fats cannot be absorbed. Okay, now in the case of the mucosa, if you have an inflammatory condition of the mucosa, whether it's because it's caused by an infection or the lack of an enzyme, the person will have atrophy of the gastrointestinal mucosa, and that can prevent the nutrients from being absorbed. You can have obstruction of the lymphatics, and the lymphatics are important to absorb the fats. So what can lead to obstruction of the lymphatics? Well, neoplasm or infectious processes. Food allergies can also lead to problems of the digestive system. So some of the food allergies are coming to a specific nutrients, like proteins that are found in eggs, in peanuts, uh, allergies to the sugars that are found in milk, to nutrients that are found in soy, fish, etc. And the consumption of this food can trigger an allergy that can result in oropharyngeal itching, laryngeal edema, cough, shortness of breath, wheezing, nausea, all the signs and symptoms of an allergy. And if this person has suffered from these allergies for the first time, you have to make a thorough dietary history and possibly immunological testing, so that the person won't be exposed to these nutrients again, and the person can free up itself from an adverse reaction that sometimes can lead up to death. So the general manifestations of altered nutrition will be weight loss or gain if the person has poor absorption or overabsorption of the nutrients, muscle wasting and weakness, changes in the skin and the mucous membranes, problems with wound healing in the case of the lack of absorption of proteins, dehydration, diarrhea, abdominal pain, and fatigue. The treatment for many of the problems of altered nutrition will be, of course, to assess the intake of the diet in the person and measure the height and weight to calculate the BMI, the body mass index. And also you can perform some lab tests like CBC count in the case that you suspect that, for instance, if someone has an ulcer in the mucosa and is bleeding, if you may, it's going to have poor absorption of nutrients, and the person in the CBC is going to show low levels of red blood cells. You can also perform a sedimentation rate test, which also tells you if the person has low levels of red blood cells. You can also assess the levels of electrolytes, and you can perform a urinalysis and urine culture. So some of these dietary interventions will be specific to the problem that you are suspecting. So if the person is lacking a particular macronutrient, you will ask the person to increase the intake of that macronutrient. If the person is lacking certain vitamin or mineral, you will ask this person to take a supplement of them. If the person has overweight, you can reduce the overall intake of calories. If the person has an allergy, you will avoid this specific food. And you can also give exogenous enzymes in the case of when the person is lacking an enzyme, like in the case of pancreatitis, or in the case of the person if it doesn't have lactase, the enzyme that breaks down lactose, you can give exogenous lactase. Okay, so now let's move into the concepts of altered nutrition. So first, let's start with iron deficiency anemia. So anemia is the reduction of the red blood cells and the consequent reduction of hemoglobin levels. The major causes for anemia will be the lack of iron in the diet, if the person has a chronic hemorrhage, if the person cannot absorb the iron, or if the person has a physiological state in which the person requires more iron than usual. Now, iron is necessary for the synthesis of hemoglobin and also for the transport of oxygen. And iron, it is found in not only hemoglobin but also in enzymes or myoglobin, and it is transported in proteins like ferritin, hemosiderin, and transferrin. And iron balance is maintained through the careful regulation of iron absorption by the small intestine. And when our erythrocytes get destroyed after they have accomplished their function every 120 days, we have to recycle this iron to make more red blood cells. Now, one of the important things is that there can be many causes for iron deficiency anemia, including the lack of intake of iron in our diet. But also, what if the person has a problem in the absorption or in the transport of iron. Okay, so we can have more than one cause. Now, one of the diagnostic criteria for iron deficiency anemia is performing these tests like blood smear, in which you will see the erythrocytes in a microscope slide. And when you see these erythrocytes in the microscope slide, you will see that the number and the quality of red blood cells is reduced. So you will have what we call hypochromic and microcytic anemia, which means that your red blood cells are going to be pale, like in the case of this one, because you don't have enough hemoglobin. And they will be small because you will not have iron to deposit hemoglobin, and your red blood cells are going to be small. Now, the signs and symptoms. So sometimes, especially when it starts, it can be asymptomatic. But as this anemia, it progresses, the person can have pallor in the skin and the mucous membranes, because the red blood cells will be pale as well at some point. They won't be as reddish as the other red blood cells. And the person is going to be weak, so you won't have enough transport of oxygen into the tissues, so that the tissues won't function as well, including the neurons. They won't be functioning as well, so you have lightheadedness, the person can have syncope, and the person will have headache. Now, another clinical manifestations will be breathlessness, palpitations, tachycardia, brittle hair, nails, mouth sores, and pica. Pica refers to the craving for actually things that can contain iron, like soil, for incredible as that sounds. Diagnosis is through history and physical examination. You will perform tests like measuring the levels of hemoglobin, which is going to be low. Also, you can perform a hematocrit, which is counting the percentage of red blood cells, and of course it's going to be low. Mean corpuscular volume is referring to the actual volume that the red blood cells have, and it's going to be decreased, similar as to the mean corpuscular hemoglobin concentration, and red blood cell indexes, and serum ferritin. Treatment, it will be depending on the cause. If you suspect that the person is not having enough intake of iron, you will give an iron supplement. But if you give this iron supplement and then you retest the person with a CBC count and with a blood smear, and then you see that there is no improvement in the CBC count, and then if you still see in your in your blood smear, if you still see the erythrocytes, which are pale and they are small, then you might be suspecting of an absorption problem of iron. And in that case, you will have a different approach. So the treatment is going to be specific for the cause. And so if the person doesn't improve, then you have to tackle different approaches. Okay, now for anorexia nervosa. So this is an eating disorder. And this eating disorder is characterized by the inability to maintain a minimally healthy body weight. And the person will have an intense fear of gaining weight. You will have relentless dietary habits that prevents the weight gain, and is going to have severe body image distortion. Now, the term anorexia designates the lack of appetite, but the lack of appetite in this case is going to be related to a psychological problem. This is particularly happening in developed countries that value a thin body type. So socially, the person is going to be pressured to have a thin body type, and that can affect the perception of the person. Now, anorexia nervosa can happen in both male and females, and at some point, this anorexia nervosa has greater risk factor in females, and you have another risk factor like having a family history of anorexia nervosa. The person can also be having an introverted personality, an obsessive personality with a perfectionist style, and the person might not have the ability to resolve conflicts, might have low self-esteem, might have family dysfunction like enmeshment, overprotectiveness, etc. And at some point, you have to have this approach of different groups in the medical health field to help the person. So clinical manifestations will be having a restricted caloric and nutrient intake, and the person will have this extremely thin stature, lanugo, which is basically having a very thin hair, like it looks like the hair that the babies have when they born. The person will have amenorrhea because you will have the lack of secretion of FSH and LH by the pituitary gland. The person will have hair that is very thin and brittle, and also the person will have peripheral cyanosis because it will have anemia. The person will also have dry skin, bradycardia, hypotension, hyperthermia, abdominal bloating, and also will have constipation. Now, in the case of the low blood pressure, will be also accompanied by slow heart rate, and the person can go up to having heart failure. So you have to have then again for diagnosis and for treatment an interdisciplinary approach. So you have this diagnosis from the DSM-5, which has these criteria. So the person will have restriction of food intake relative to caloric requirements that leads to low body weight, and the person will have an intense fear of gaining weight or becoming fat even though the person is underweight, or the person will have a persistent behavior to avoid gaining weight even though the person is underweight. So there is a discrepancy. The person will have a low body mass index. And then the person will have disturbance of the body image, in which the person will have undue influence of body weight or shape on self-evaluation, and persistent lack of recognition of the seriousness of the current low body weight. And then in the nutritional assessment, it will often reveal a restriction of caloric intake to less than 1,000 kilocalories per day. That, by the way, in general, an adult has a minimal kilocalorie intake for the basal metabolic rate of at least 1,500 kilocalories per day. That's when the person is not doing anything. Imagine after that, whatever level of activity you have to add more calories into that. Now you have to do some lab testing that can include blood tests that assess electrolytes, so the person will have hypocalcemia, levels of proteins you have to assess, electrolytes, etc. And even you can have an EKG to see if you have any problems with the functioning of the heart. So treatment, again, it's interdisciplinary, and in this team, you should include the patient's family, psychotherapists, physicians, nurses, dietitians, recreational and occupational therapies. And the goal is to make the person to gain at least 1 pound per week to optimal, and then keep monitoring the person for complication and disturbances, and keep giving psychotherapy so you don't have a recurrence of the problem. Okay, now let's move into celiac disease, which is gluten sensitivity enteropathy. In celiac disease, you have malabsorption of gluten. So gluten, it's a protein that it is found in foods like wheat, rye, oats, and barley. And the gluten contains an amino acid that is called gliadin. And the person will have T cell mediated hypersensitivity against this gliadin. So the person, sorry, the person cannot ingest gluten because it will have an allergic reaction. Now, this disease or this condition is most often detected between the infancy and young adulthood. And the cause is often unknown, but there is a strong component for heredity. And the person will have clinical manifestations that are consistent with the malabsorption, like the person will have weight loss, diarrhea, flatulence, which is basically gases, steatorrhea, which is having fat in the stools. The person will have malodorous stools. The person will have loud sounds in the stomach or intestinal rumbling, which we will call borborygmus, and the person will have bloating. And since the person won't be able to absorb nutrients, because one of the things that happens is that the intestinal villi become atrophic when the person is exposed to this gluten, then the person won't be able to absorb many macronutrients, so the person will have nutritional deficiencies and the person will have fatigue. So the diagnosis is based on the clinical manifestations, and the person will have in the labs, when you ask for detection of antibodies, the person will have antibodies against gliadin, against endomysium, and against tissue transglutaminase. And then the diagnosis is given by a biopsy of the intestinal cells, in which you have inflammation of these intestinal cells and atrophy of the enterocytes. So the treatment is to completely eliminate gluten from the diet of the person, and the person can still have some other macromolecules in their diet, like corn and rice, because they don't have gluten, so they will provide carbohydrates to the person. And the person can have also supplements of vitamins and minerals, and you will have to take some during acute periods of celiac disease, can take anti-inflammatory drugs and hypersensitivity blocking medications that can help to reduce the inflammation of the enterocytes. The enterocytes can return to their normal size and state within 1 to 2 months after the person has eliminated gluten from their diet. So this is it's very good because that means that the person will have permanent damage and it can regain absorption of different macronutrients. Okay, so for phenylketonuria, so this is an autosomal recessive disorder that it is the result of a mutation of a gene that is called PAH gene, and this PAH stands for phenylalanine hydroxylase, which is an enzyme that is going to metabolize phenylalanine. Now, phenylalanine, it is converted by this enzyme phenylalanine hydroxylate into tyrosine. And then tyrosine is an amino acid that it is necessary to make different proteins. Now, if you don't have this enzyme, this PAH enzyme, you will start accumulating phenylalanine within the body fluids. And this is going to lead to these byproducts, and it's going to be toxic for the brain. And along with that, you have the absence of tyrosine. So tyrosine is necessary for the development of the brain. And in the case of phenylketonuria, is inherited. So the proportion of babies that born with phenylketonuria is very high. So it's about 350 of every 1 million births. So this is the most common genetic defect that leads to problems in the babies in general. Now, the clinical manifestations are going to be based on the effect that it has in the brain. So excess of circulating phenylalanine is going to impair the cognitive function. So the person is going to have phenylalanine in high levels that is going to impair intellectually the person. And along with that, the person is going to have impairment of melanin synthesis because melanin synthesis requires tyrosine. So in the persons without melanin, the person is going to have fair skin and is going to have hyperpigmentation of the eyes and the hair. And the person will have musty odor and because of the accumulation of this phenylalanine, and also the person is going to have seizures. Now we have diagnostic criteria in which you can have after the baby has born, you can have this routine metabolic screening blood test that tests for the absence of this enzyme. So in countries without routine screening of the newborn, phenylketonuria is often undetected, and you only detect after the person has developed intellectual disability. The treatment, the persons require specialty care. So the condition is treated with carefully limiting the intake of phenylalanine for life. And you start adding amino acids like tyrosine in their diet, also vitamin and supplements of minerals. Pharmacological therapy with different drugs like sapropterin dihydrochloride, which is an enzyme cofactor, may support the metabolism of phenylalanine in some patients, but this is research that is going on, and some of them they respond to this therapy, some of them they don't. So some of these specific food restrictions then for phenylalanine includes those that are high in protein like meat, dairy, nuts, dairy products, nuts, beans, and starch, and acceptable foods that will be those that are low in protein, including fruits, non-starchy vegetables. Now, obesity. So for obesity is the state of excessive body fat, and it's a major public health crisis. So the prevalence of obesity worldwide has increased so much that we have an estimate of having 1 billion people who are overweight or obese. Now, obesity has several risk factors, including genetics, lifestyle. If someone is sedentary and it's overeating food, of course, that it's a major contributing risk factor for obesity. Also, the person might have impairment of the secretion of certain hormones like leptin, estrogen, thyroid hormone, insulin, etc., and that can lead to obesity. Obesity is subclassified according to the body mass index. So if someone has a body mass index between 30 to 35, that will be classified as obesity type 1 or class 1. Over 35 but not reaching to 40 will be type 2, and over 40 will be class 3 or extreme obesity. So the clinical manifestations will be having excessive weight and body fat, and the fat will be distributed within the truncal abdominal area or the glutofemoral area. Now, obesity has several consequences. So the person will have greater chances of having diabetes, heart disease, hypertension, hyperlipidemia, and hyperlipidemia, of course, is going to lead to deposit of fats within the blood vessels, which will lead to strokes, ischemic strokes. The person will have joint pain or osteoarthritis. The person can have liver disease, poor wound healing, sleep apnea, because part of the fat deposits in the neck, so the person won't be able to breathe really well, and certain cancers. So these are comorbidities basically of obesity. Diagnosis is through history and physical examination. So you have to calculate the BMI. So basically you divide the height divided by the weight in metric units, and then you classify the obesity according to the graph that we already saw. So these are the comorbidities that I already mentioned. And then the treatment will be having these lifestyle interventions that hopefully will last for life. And the goal is to have an optimal health, of course. So the basic treatment principles will focus on diet, exercise, and behavioral modification. Part of the treatment can include pharmacological therapy or surgery, but these, of course, do not replace lifestyle modification, and pharmacological therapies will primarily aid to suppress appetite, increase metabolism, or interfere with fat absorption. Okay, so this is all for chapter 17. Now, chapter 18 is about altered elimination. So, elimination processes will require the motility of organs and also the patency or the open of these structures within these organs. So you can mobilize the wastes for excretion. One of the systems that it is used for eliminating wastes is the urinary system. And within the urinary system, we have the urine, which is the fluid that it is produced by the kidney. And this fluid, of course, is stored in the urinary bladder and is excreted by the urethra. Now, one of the functions of the renal system or the urinary system will be to regulate the amount of volume that we have in our body, and also to regulate the composition in terms of how many electrolytes do we have, how many do we keep, how many would we will get rid of, and eliminate the wastes like nitrogenous wastes like urea, uric acid, etc. And within the urinary system, within the kidneys, we also secrete and produce some hormones. So some of the hormones will be erythropoietin. We also produce some enzymes like renin that helps to regulate blood pressure, and we activate these vitamins like vitamin D. This is the figure that shows you the parts of the urinary system. So we have the kidneys in here within the lumbar area, and then we have here the renal pelvis that connects to the urinary ureter that connects to the urinary bladder, and then we'll have the urethra afterwards. Now, if you make a section of the kidneys and you see the structures, you have here the cortex, which has these nephrons, which is the structure and functional unit of the urinary system. And then we have the renal columns in here separated by the pyramids, which are triangular shaped structures that helps to collect all the urine produced by the nephrons. And then we have the blood vessels that provides blood supply or drain the blood supply from the kidneys, which will be the renal artery and the renal vein. And then within this area of the kidneys, we have the renal pelvis that it is formed by these calyces that are going to drain the urine into the ureter to be brought into the urinary bladder. So the nephrons are made of different segments. So we have here the renal corpuscle, where we have the glomerulus that is going to filtrate our blood, and then we have these tubules. So we have the proximal convoluted tubule next to the glomerulus or the renal corpuscle, and then we have this loop of Henle with a descending limb, a loop of Henle, and then ascending limb, and then we have the PCT, the DCT, distal convoluted tubule, that is going to drain into the collecting tubule. Now, basically, when the blood supply comes into the glomerulus, through this process of having high pressure within these capillaries, the glomerulus, we filtrate the blood. And this filtrate is going to go into this capsule, into this capsular space. And some things that it's supposed to go into the filtrate will be water, nutrients, like amino acids, glucose, vitamins, minerals. But something that shouldn't go into the filtrate will be red blood cells and proteins. And this filtrate will go then into the different segments of these tubules, into the PCT, the loop, and to the DCT, and we will have absorption of nutrients and water within the PCT, and then we will have and also the absorption of electrolytes within the PCT, and then within the loop we will have variable absorption of water, absorption of sodium chloride within the loop, and then here within the DCT or the distal convoluted tubule, we can still have some absorption of electrolytes and water, but mostly within this area we secrete things that we don't need, like urea, uric acid. So we will have secretion within this area while we have absorption within this area. And then all the fluid from that travels from the PCT up to the DCT will be called tubular fluid. Once this fluid is emptied into this collecting tubule, you will have what we call the urine. Okay, so filtrate is the fluid that reaches the capsular space or the Bowman's space here. And then tubular fluid will go from the PCT up to the DCT. And from the DCT emptying into collecting tubule, you will have urine. Now, within the collecting tubule, we can still have absorption of water under the influence of aldosterone, but only when someone is so dehydrated. And within the collecting tubule and even within the DCT, we can control the pH because we can secrete or absorb hydrogen ions. So we can perform this balance of the pH. So what is the role of the nephrons? To filter substances from the blood. Remember, within this filtrate, everything can go except proteins and red blood cells. And then within the nephron, we'll reabsorb the nutrients and the water, and we will secrete the waste. Now, the kidneys will filtrate around 1,000 milliliters or a little bit over 1 quart of blood per minute. So basically, if you multiply that times 60, which is 1 hour, that will give you 60 liters per minute. If you multiply that times 24, that gives you a lot of blood that we filter per day. And this filtration is basically 20 to 25% of our cardiac output. So the kidneys are very important. And then the kidneys will receive then this blood supply through the renal artery, which will reach these afferent arterioles, which will bring the blood into the glomerulus, and then the blood from the glomerulus exits into the efferent arterioles. So this is the microcirculation of the kidneys, and then the blood will be returning into the peritubular capillaries and into the vasa recta, which are surrounding the tubules and the loop of Henle. So the urinary filtrate starts at the Bowman's capsule, and then it travels or gets transferred into the tubular system, into the proximal convoluted tubule, into the loop of Henle, and then into the distal convoluted tubule. And as this tubular fluid travels through this tubular system, you will have exchange of water and electrolyte with the interstitial fluid, the fluid that surrounds these tubules, by what we call a countercurrent mechanism, in which you can have reabsorption and secretion. So reabsorption will be bringing fluids from the filtrate into the circulation, and secretion will be the opposite. So you will bring substances from the circulation into the filtrate. And then out of this exchange, finally you can concentrate urine, and you will excrete urine. So this is how you form the urine. So whatever filtrate passes into this descending part of the loop, and to the ascending part of the loop, and then into these PCTs and DCTs, you will start absorbing the nutrients in water here within the PCT. And then as the filtrate goes, the tubular fluid goes through these different segments of the descending loop, as you can see here on the left, you have different osmolarity or different concentration of solutes. So you start here in the PCT with 300, 400 milliosmoles per liter, so you don't have so much concentration of solutes within this region. And then you start absorbing water here in the vasa recta. And then as you go down, you will increase the concentration of solutes within this region. Why? Because you're absorbing water, so you're leaving more solids here. And then you start decreasing the amount of water that you absorb. However, here within the loop of Henle, since you have more and more concentration of solids, you will secrete part of the water into this region. And then as you go up, you will start absorbing less water into this region, and you will bring sodium chloride out to dilute this fluid that you have in here. And then you will have something that we call free water, and then you will have secretion of substances here within the distal convoluted tubule, and then you will reach this part of the collecting tubule in here, in which under the influence of aldosterone you can have absorption of water if it's necessary, and you can have absorption and secretion of potassium, so you can have as well some sort of exchange of sodium for potassium within this region. So you can start controlling more absorption of water if you have more sodium available, and then at some point you exchange that for potassium. So as you are absorbing sodium, you are getting rid of potassium. So that's what happens. Now the urine then will enter into the ureters via the renal pelvis, and then it will be transferred into the urinary bladder by peristalsis. So you have smooth muscle within the walls of the ureters, so they will expand and collapse, and then they will bring the urine into the urinary bladder. And as the urinary bladder is receiving the urine, you will start activating these stretch receptors that are located within the muscular wall of the urinary bladder, which is called the detrusor muscle. And these stretch receptors, as they are getting stretched, they will send a signal into the spinal cord using these sacral nerves, and then you have a reflex through these parasympathetic motor fibers, cholinergic motor fibers, so that you can have contraction of these urinary bladder, so you maintain a specific tone of this detrusor muscle. And as the urinary bladder is getting more full, you will keep relaying information into the spinal cord, and then that information will travel up into the spinal cord, going and reaching to the thalamus, and from there you filter that information into the cerebral cortex, whether it's important for you to go and pee or not. If you feel that, or you sense through the cerebral cortex that you have enough volume in your urinary bladder that is necessary for you to go and pee, you will send an efferent signal back into the spinal cord and then into the urinary bladder, so you can relax your internal and external urethral sphincters, so you can eliminate urine through micturition. Now the internal urethral sphincter is located at the neck of the urinary bladder, is made out of smooth muscle cells, and this is under the influence of the parasympathetic system. Now the external urethral sphincter, the one that we have at the end of the urethra, this is made out of skeletal muscle and is under the influence of the somatic nervous system. So the pudendal nerves will bring this signal into the external urethral sphincter so that you can relax it and then you can urinate. Just this is to show you the structure of the urinary bladder. So you have an epithelium here, which is called transitional, in which the cells are cuboidal when the urinary bladder is empty, and as the urinary bladder is getting full, these cuboidal cells will transform into squamous cells. So that's why it's called transitional. And as the urinary bladder is getting full, these stretch receptors that are located here within the detrusor muscle will sense this signal, will have this uh, reflex going on between the spinal cord and this muscle through these afferent and efferent neurons, and then you can start this micturition. And in here it shows you that the urine is brought into a urinary bladder by the ureter into this triangular zone inside the urinary bladder. It's called the trigone, and then the trigone empties the ends in this region where you have the internal sphincter, and then here you have the external urethral sphincter. So the urine has these characteristics. So it's supposed to be yellow, clear yellow in color, and it's supposed to be clear, and it has to have a mild smell like ammonia, because the nitrogenous wastes that we get rid of has a little bit of ammonia, NH4. So the total volume can vary according to your intake of water and your capacity of producing urine, which will be normally between 750 to 2000 milliliters over a 24-hour period. Now, if someone has darker color than yellow, that can indicate dehydration, but it can indicate also some problems of genetics. So that can be detected later on, depending on how dark is the urine. So another thing that you shouldn't see in the urine is cloudiness, because if someone has cloudy urine, it might indicate that the person has an infection. In order to analyze the urine, you can have a macroscopic analysis and microscopic. Macroscopic is just to see the color and if it's turbid or not, if it's clear or not. And then you can have also biochemical analysis, in which you, with the dipstick, can analyze the components of the urine, like pH, which usually the pH of the urine is acid, a specific gravity, which is supposed to be a little bit over the specific gravity of water, which is 1, and then contents of protein. Again, I told you that we shouldn't have any protein in our urine. Why? Because protein is important for maintaining the blood volume in our blood or in our body. So if you have protein, that means that you have in your urine that you have glomerulonephritis, or you have inflammation of the glomerulus. Same for glucose. Glucose, we shouldn't have any glucose, because if someone has glucose, that means that he has glomerulonephritis. In the case of diabetics, they usually have glucose. Diabetics, sorry, they have glucose in their urine. Ketone bodies. So ketones are byproduct of the use of fats as a source of energy. So if someone has ketosis or ketone bodies in their blood, they will show in urine. So that means that the person is starving, or the person is diabetic and he has a lack of macromolecules like fat or proteins. Nitrates or nitrates indicates the presence indicates infection, similar for leukocyte esterase. Positive test. Now you can do microscopic analysis, in which you can centrifuge urine sample and look for the presence of crystals, casts, squamous cells, white and red blood cells. And if you do, that mean if you do have any of them, that can pinpoint to a tubular problem. And then if you have bacteria, of course, that means that you have an infection. Even you can have not only bacteria, but you can have fungi. Viruses is hard to detect, but you can have infections within your urinary system. Okay, so problems of elimination of urine can be because your ureters or your renal tubules are not well, not the renal tubules, but the ureters that are not contracting properly. The renal tubules might be obstructed, and whenever you have altered mobility, you have stasis, or basically a stagnation of the urine. And stasis can happen at several levels, like it can happen within the renal tubules, within the kidneys, of course, and it can happen within the urinary bladder, it can happen within the ureters, it can happen within the urethra. And whenever you have stasis, you can have precipitation of salts within the urine. And in the case of that, you can have the formation of little stones or lids that we call, and then you can have obstruction, and then you can have backing up of pressure within the urinary system, and that can lead to problems of reabsorption and secretion. So here is the case of acute tubular necrosis caused by an obstruction. In the case of having obstructions or cellular debris or casts within the collecting duct or the DCT, that can lead to necrosis within the proximal areas, like in the case of the descending limb or the PCT. And that, of course, can lead to problems in the glomerulus, which, by backing up the pressure, which can lead to necrosis, and the person will have ultimately renal failure. Another problem that it can happen is that the person have a neuromuscular problem or neuromuscular function. So the person have failure or exaggerated neural signal transduction because he has problems within the nerves, or the person might have over-responsive muscles or under-responsive muscular walls within the urinary bladder, within the ureters, etc. Consequences of this will be having a limited ability to eliminate the urine, or retention of urine, or incontinence. Another problem can be altered perfusion. So the person can have inadequate blood supply because there is an emboli within, or an embolus within these blood vessels that provide blood supply to the different structures within the urinary system. So depending on the size of the blood vessel is whether you have focal or global consequences. It's not the same having obstruction of the renal artery by a plaque, complete obstruction of the renal artery, than having an obstruction of a small branch. So if you have complete obstruction of the renal artery, of course you will have complete problems in the kidney. So you will have global consequences. Okay. So consequences of altered perfusion. So you have poor oxygenation, so you have ischemia, or you can have infarction, and then that can lead to hypoxia and pain. Altered patencies, when you have blockage within these tubules or within this renal pelvis or the ureters, the lumen, you will have lack of elimination. So you can have internal obstruction of this structure or external. What if you have a tumor outside of your ureters that is compressing one of the ureters? So in that case, you won't have elimination of urine. Why? Because the urine cannot be descending through this ureter, so you will have this accumulation of urine within the side that it is affected, the right or the left. So the consequences will be blockage of the urinary flow, dilation of the structures proximal to the obstruction, which is called hydronephrosis in the case of the kidneys, and stasis of the urine. Whenever you have stasis of the urine or stagnation, whenever the urine doesn't flow, you have greater chances of having infection, because the urine, as it's flowing from proximal to distal, is having a flushing action. So it's basically flushing away microorganisms. And then you have injury to the structures within the kidneys. So this is an example of hydronephrosis. So if you have here an impacted stone at the entry of this ureter towards this urinary bladder, you have the kidneys, as they are producing the urine, they will having no urine coming on this side. In the case of this side is left. So you have accumulation of urine inside the ureter, and then this pressure, it keeps building up in the ureter, keeps going up into the kidneys, starts distorting the pelvis. So this will be a dilated pelvis, and then it starts distorting the calyces, and then all the different regions of the kidneys, like the medulla, here the renal papillae uh, within the pyramids. So you can start with an early edematous phase, so the kidney will be all edematous because it won't be able to flush the urine to the ureter, and then you can go into a progressive phase in which all these cortex, these nephrons within the cortex start getting damaged, and then you start having scars or fibrosis, and that can lead to atrophy within these nephrons and necrosis, of course, which will lead to kidney failure. So the general manifestations, you can have altered volume excretion, so you can have less volume being excreted. You can have altered excretion characteristic. We already talked about the color of the urine. Sometimes you can have cloudiness within the urine. You can see red blood cells, hematuria, which of course it will make the person to worry. The person will have pain, distension, anorexia, nausea, vomiting, fever. Why? Because you have accumulation of toxic products within your blood. So diagnosis is through microscopic urinalysis, also determining the glomerular filtration rate. If it's low, that can pinpoint to having renal failure, counting the elimination of certain substances like creatinine. So we have something that's called creatinine clearance rate. If it's low, that pinpoints as well to abnormalities within the filtration of creatinine. You can do imaging studies like looking at the structures within the kidneys, like intravenous pyelogram, renal angiogram, just to see if the blood vessels within the kidneys are not obstructed. You can see the kidneys, the size, the shape, the volume with the renal ultrasound. And for the treatment, will be administering fluids if it's a deficit, give diuretics if it's an excess, or just give antibiotics if there is an infection. So there's several treatments. Okay, so now for elimination of wastes through the digestive system. So we have stool elimination, and stool elimination is given by the colon. Now, the colon is supplied by the inferior mesenteric arteries and is innervated by the parts of the ANS, like sacral nerves or the vagus nerve. So what are the components of the large intestine? Will be the cecum, the initial portion. Next to the cecum, we have the appendix, and then we have the ascending, transverse, descending, and sigmoid portions of the colon, and then we have the rectum and the anal canal. And in here you can see the innervation of the colon with the sympathetic system and the parasympathetic system. So we have the innervation of the colon with the parasympathetic system through the celiac ganglion, superior mesenteric ganglion, inferior ganglion. So all of these fibers, the postganglionic fibers of these ganglions, go and reach the different regions of the colon. And then with the sympathetic system, we have the pelvic nerves coming from S2 through S5, or sacral nerve 2 through sacral nerve 4. And then through these pelvic nerves, they innervate the rectum and the distal portion of the colon. Now, through the vagus nerve, we innervate the different viscerae and the proximal portions of the colon. So in the stool elimination process, the fecal matter will enter into the cecum, passing through the ileocecal valve. So the ileum will transfer then the feces or the food that we didn't ingest into the cecum. And then the ileocecal valve will open and then close, preventing the backing up of the feces from the colon into the small intestine. Now, once the cecum receives this volume of non-digested food, you will start transferring this undigested food from proximal regions of the large intestine into distal region through peristaltic movements. So we will have within the walls of this colon, we have stretch receptors. And as these stretch receptors get stimulated by the presence of food, you will start this action potential within these nerves that starts peristalsis, which will be expansion and contraction of these regions through segmental regions that will lead to segmental movements, and then these segmental movements will lead to mass movements in which you move stools from proximal areas into distal areas. As you are doing this, you start removing water and electrolytes, and then you start compacting this material to form the stools, and finally these stools will reach the rectum, will lead to expansion of the rectum. Again, we have stretch receptors that can detect how stretched are these cells, and then you will start the elimination process through relaxation of the internal and external rectal sphincters. And similarly, as to these sphincters that we have within the urinary bladder, or sorry, the urethra, we have an internal sphincter is made out of smooth muscle that is under the control of the ANS, while the external sphincter is made out of skeletal muscle, which is under the control of the somatic nervous system through the pudendal nerves. So this is under voluntary control, then the external, and the internal is under involuntary control. And the same, the process of defecation happens through these reflexes that we have that happens between nervous system that innervates the spinal nerves, that innervates these portions of the large intestine, especially the rectum, and this connection to these nerves in the spinal cord, and then with the input going into the cortex, and then a reflex going back into these nerves, the sacral nerves, and then into the pudendal nerve, so we can start defecation. So the trigger point is distended rectum that leads to an afferent impulse that will reach the spinal cord, the sacral region, of course, that reaches the cortex. Again, in the cortex, you start filtrating the information, whether it is time to go and poop or not. And then you send this reflex back into the spinal cord, and then you decide whether to defecate or not. And then if you do, you will relax your both internal and external anal sphincters, but if you don't, you will contract them. So characteristics of the stool will be having water contents that is very small, 100 milliliters. So you receive usually from the ileum non-digested food that contains like around 700 milliliters of water, depending on how much water you have ingested, but usually that's the amount. And then from there you absorb water and you leave like 150 milliliters. And then the solids will be 25 to 50 grams that will have unabsorbed nutrients that actually are going to be used by the bacteria, the flora, the normal flora that we have in the large intestine. And these bacteria will use these nutrients not only for its own survival, but also to make for us vitamins like certain vitamins B and vitamin K that help us as well. And then we have sloughed epithelial cells coming from the mucosa, bile pigments that gives the color to our stools, and we can have fat between 10 to 20% in undigested dietary fiber depending on your normal diet, but it can go up to 30%, inorganic solids 20%. Physical characteristics will be having a brown color given by this pigment stercobilin, and the color will change according to the diet. Volume and amount is frequently variable. We usually have an average of 200 to 300 grams of stools eliminated per day, and the texture, it is soft, moist, semi-solid, or hard, depending as well in your diet that you intake. So the analysis of the stools includes the physical characteristics that we mentioned, together with the shape, the odor, the volume, the consistency, the color, and the elimination patterns. So how many times that the person goes per day, per week, etc. Now, problems of bowel elimination will be altered mobility, in which you have altered water and vitamin absorption, altered storage time, risk of obstruction, and then consequences, which will be constipation and diarrhea. Altered bowel elimination also, similarly as what happens with altered urine elimination, can be influenced by perfusion. If you have an obstruction of one of the blood vessels that gives blood supply to certain regions of the bowel, of course, you can have focal consequences or global consequences. Also, you can have, of course, ischemia or infarction and pain that can lead, in case of infarction, to perforation of the regions of the bowel, and then of course that can lead to peritonitis and death if it's not treated properly. So the person can have septic shock. Altered patency, you can have internal obstruction because you have impaction of feces. You can have tumors growing inside the the lumen of the different regions of the colon, or you can have obstruction externally as well. You can have external tumors growing. Okay, consequences will be having distension of the proximal regions, impermeability, necrosis, and perforation, because you have pressure that exceeds the ability of the tissue to retain its structure. General manifestations of altered bowel elimination will be having altered stool volume and the characteristics. You can have bleeding, which will be melena, in which you will have stools that looks like it will have coffee grounds in it, so that's partially digested blood. Or you can have occult blood in which you cannot see the blood, but you can have this test that can detect the presence of red blood cells. Or you can have plainly blood within, like bright red blood within the stools, that can pinpoint to a problem within the lower regions of the colon, like in the case of cancer within the rectum, within the sigmoid, etc. Of course, you can have pain as well, because you can have inflammatory processes. You can have abdominal distension if you have an obstruction, anorexia, nausea, vomiting, and fever. Diagnosis is through studying characteristic of the stools, having x-rays or any other imaging study, which includes CT scans, MRIs. You can perform endoscopy as well of the sigmoid or of the colon. You can take samples, biopsies, and treatment will be, of course, to treat the underlying cause. Now let's move into specific problems. So appendicitis, basically it's obstruction of the appendix, usually by a fecal light, which is basically stool obstructing the lumen. When you have that, you have inflammation in the appendix that can lead to pain in the right area, in the right lower quadrant, and you have fever. You will have also leukocytosis, many things, and this can lead to perforation of the appendix and then appendicitis. So this is a medical emergency. In colon obstruction, you can have a tumor like adenocarcinoma of the colon, in which you can have proximal distension of the regions of the intestines. Now, in the case of this process of altered elimination, at some point you can have this ultimately alters body fluid balance, because you won't have absorption of this water, which is probably not so much, but that ultimately can lead also to body fluids imbalance. Okay, now let's talk about a specific problem. So urolithiasis, which will be having calculi within the kidneys. And this can happen because you can have an acid-base imbalance that can lead to precipitation from the urine within the kidneys. And that will lead to the formation of these kidney stones, of different types of kidney stones with different type of composition, but ultimately you have obstruction, and that obstruction will lead to urinary stasis, and that can lead to elevation of salts, organic and inorganic acids, and your renal tubules can have obstruction. And when you have obstruction of the renal tubules, you'll have this urine as it is formed but not eliminated, causing pressure within the renal tubules, and that can lead to the formation of necrosis. So here is showing you some of these types of kidney stones that you can have in the problems. So you can have urate calcium salts deposited within the renal parenchyma, which is going to lead to necrosis of the renal cortex. Also, you can have deposit of urate salts within the pelvis, which is going to lead to stones within the pelvis, and they can accumulate if it happens within many renal calyces that can lead to a large staghorn stone. These, since they are very large, they cannot be eliminated, and that can lead to, of course, hydronephrosis, and this will also lead to permanent damage to the entire kidney, and of course they have to be taken away together with the kidney through surgery. Clinical manifestations will be having pain in the side that it is affected, whether right or left. It will be so much bad luck to have bilateral kidney stones. Usually it's a unilateral problem. And the type of pain, it will be colic, which will pinpoint to distension of the collecting system or the ureter, and the pain is going to be acute, intermittent, which is going to be located within the lumbar area, radiating anteriorly or superiorly, and the pain is going to be excruciating. Now you can have another pain that is non-colic, that it is caused by the distension of the renal calyces or the renal pelvis, and this is characterized as dull and deep, and it can range in intensity from mild to severe. Now, hematuria also can be present because you can have these little peaks within the stones that can damage the epithelial cells within the renal tubules or within whatever structure they are nearby. And the manifestations can range from gross hematuria to red tinge color change in the urine. Now, along with that, the person can have nausea, vomiting, dysuria, and urgency. Diagnosis is usually done by subjective findings like history of pain and imaging like a CT scan or an ultrasonography. And also you can have this analysis of the composition of the specific salts that you found within this calculi. Like sometimes you can have calcium oxalacetate salts or calcium phosphate salts, magnesium, ammonium phosphate, or estruvite salts that pinpoint to a urinary tract infection. Treatment, it is supportive depending on the size of the calculi. If it's large, of course, you have to perform surgery, but if it's small, you can wait a little bit to see if with your pharmacological treatment you can eliminate these calculi, but you have to, of course, give medication for pain control. And then you can increase the fluid intake in the person, and if the person is retaining the stone, it has constant pain over a reasonable period, of course, you have to perform surgery, in which you can have this assessment also as well of how much damage you have within the kidneys. And also there is this treatment that it is reducing the size of the calculi with what we call extracorporeal shockwave lithotripsy, in which you can give some sort of ultrasound to start breaking down these large stones into smaller ones, and then hopefully they are so small that they can be eliminated spontaneously. Best treatment prevention with diets that are low in foods that are rich in calcium oxalate. Okay, so for urinary incontinence, so another name for this is enuresis, which is basically a symptom is the inability to voluntarily prevent the discharge of urine. And in incontinence, this is characterized by having this impaired muscular contraction, because you might have problems in neuronal transmission given by problems in the nerves, or you can have hormonal stimulation or mechanical factors that can lead to incontinence, like coughing, sneezing, laughing can lead to this incontinence. So usually it is determined by classification. So you can have a stress incontinence in which you have exertional stimuli like the one that I already mentioned, or you can have urge incontinence in which you have an overactive bladder, because you can have inflammation of the detrusor muscle, or you can have these receptors that are overreactive. You can have overflow incontinence in which you have excessive bladder capacity, or functional incontinence, which is characterized by having normal bladder control coupled with impaired ability to transport to toilet facilities. Or you can have within there as well nocturnal enuresis or continuous leakage, post-void dribble, or extraureteral urine loss because you have a fistula. Diagnosis criteria. So you will have a diagnosis based on careful history uh, taken by asking questions in addition to physical examination and specialized testing. And the testing, it has to be also available, and it will be influenced by the gender specific anatomical considerations. So you can have urodynamic and endoscopic testing in addition to imaging studies, and the gold standard are not necessary to establish diagnosis, but you can have some extra ones like bladder stress test, something that we call post-residual volume, in which you have something like after someone is boiling, the residual urine in the bladder is measured. And if someone has, for instance, less than 50 milliliters of urine, that indicates that the person has adequate bladder emptying, but it has other problem. And then you can have endoscopic testing like cystoscopy. The treatment for incontinence will reflect behavioral strategies, using medication and surgery, assistance with toileting, like bladder training, in which the person will learn to hold the urine for increased intervals, uh, and also give relief of mechanical obstruction if there is something that is obstructing the urine. Give medications like anticholinergic drugs that prevents this urge of incontinence because of the decreased contractile force of the detrusor muscle. Give alpha adrenergic antagonistic drugs to improve the tone and the contractile function of the detrusor muscle. Okay, now let's move into PKD, or polycystic kidney disease. So this disease, it is a genetic disease. It's autosomal dominant, and it is the most common inherited form of PKD. So we can have 90% of the PKD cases coming from these genetic mutations. And what happens with this PKD is that you have this formation of cysts, many cysts within the kidneys. This will be characterized then by this growth of fluid-filled cysts within the kidney tissue that happens bilaterally, and it will lead to progressive loss of the renal uh, nephrons. Now, usually this problem is genetics, 90%, but also it can be acquired independently of the cause. You can have the same pathophysiology. So you have cysts that it increases in size and in number, and that will lead to reduced perfusion. Why? Because you're going to start constricting your blood vessels within the urine, and that also is going to constrict the tubules, and that will be leading to more and more nephrons being affected, that ultimately will lead to renal function decrease. So characteristics is going to be enlarged kidneys. The person will have hypertension, is going to have pain in the flank, is going to have headaches, nausea, anorexia, is going to have urinary tract infections, renal calculi, hypertension, I already mentioned that, cerebral aneurysms, and diverticular disease in the case of the inherited part, because the person is going to have also cysts within the blood vessels in the brain, and also within the uh, colon. And also the person will have cardiac vascular disease. So it affects many systems. So it's a multi-systemic disease. So it's going to have cysts, the person within the pancreas, within the liver. Diagnosis is through family history, having genetic tests for detecting these defective genes, which is PKHD1, PKHD2, and having physical exams like the person might have hypertension, and also the presence of greater than 3 kidney cysts on the ultrasound, and having extrarenal cysts. And the laboratory confirmation is having low glomerular filtration, which will confirm renal failure. Okay, so chronic renal failure for them will be the major problem. The, the, the treatment will be to control pain, treatment of infections, treatment of blood pressure, and since they cannot eliminate the wastes because they will have renal failure, they have to undergo dialysis, and hopefully they will find a kidney, so they will have a kidney transplant. Okay, now let's talk about diverticular disease. So diverticular disease is having prolonged pressure on the large intestinal walls, and that will lead to outpouching of the intestinal walls. And these intestinal walls, they will have this outpouching in several places depending on what area it is affected. Sometimes you can have only outpouching within this sigmoid, but sometimes you can have it all over the sigmoid colon, or sometimes you can have it all over the large intestines. So what is going to have the person with diverticular disease is going to have decreased mobility, obstruction, and impaired perfusion of the colon. Now, the diverticulum is going to be found along the wall of the colon. And it's going to be looking like a small sac or now pouching, and diverticula will be having more than one diverticulum. So diverticulum is for singular and diverticular is for plural. Now diverticulitis is the inflammation of the diverticula. And in this case, the most common cause for this diverticulitis will be having impaction of fecal matter within this diverticula. That can lead to problems because since you have infection in there, diverticulitis, you can have perforation of this diverticula, and then of course you will have uh, peritonitis. The clinical manifestations will be mirroring those described earlier uh, for the inflammation. So the person will have abdominal pain, fever, nausea, vomiting. And the pain is the most common manifestation. Typically is going to be present on the left lower quadrant for the sigmoid colon, and it's going to be diffuse for the case when the person has diverticulum within all the colon. Now, nausea and vomiting may be due to obstruction or reduced peristalsis from inflammation, and in some cases, the person, as I told you, may have perforation, and it will have in fistulas, so will be connection between different regions of the colon and abscess development. The person also will have abdominal tenderness, and you will have rigidity, which will be basically the symptoms of peritonitis. Diagnosis is through history and physical examination, and the person also has to have, of course, these imaging studies like ultrasound, MRI, CT scans, and colonoscopy or baroenema, sigmoidoscopy. In the lab analysis, you can have bloody stools or a cold blood in the case of the starting cases. The person, if he has bleeding, you will have anemia, low hemoglobin levels, hematocrit, and the CBC count indicating infection, so the person will have leukocytosis. Prevention is the best treatment. So the immediate treatment will be having having dietary alterations that prevents obstruction of this diverticulum, and also having lifestyle alterations in which the person will have this lifestyle that promotes better toileting than the person might have before, medications that are both forming laxative and anti-spasmodic as well will help. I already mentioned this, so let's move now into our last concept, which is functional fecal incontinence. Function fecal incontinence is having repetitive voluntary and involuntary passage of stools in inappropriate places for children who supposed to be already trained. So in children greater than 4 years old. Now, in the case of this function fecal incontinence or encopresis, you can have a classification which is retentive incontinence versus non-retentive. So children will be withholding the feces from pain or fear of defecation. And the symptoms will be suggesting constipation in infants and children, which include infrequent bowel evacuation. Children will have hard feces, The children have difficulty or painful evacuation with large diameter stools, and most but not all the children with fecal incontinence have underlying constipation. Now, constipation will affect up to 30% of the children and accounts for around 3 to 5% of all the visit to pediatricians. So it's a very frequent problem. That's why we are considering here. Now, some developmental triggers for this disease will be introduction of solid foods that can impact the or can be making the stool so hard that can create pain in the children as they're defecating. Also, having toilet training and start of school attendance. So these are some of the triggers. Now, in retentive incontinence, uh, the clinical manifestations will have the children having a posture that it is preventing the children from having this the elimination of the stools, and then you will have excessive volitional stool retention with a history of hard and painful bowel movements, as I already mentioned. And this when the children has this finally this defecation, the fecal matter is going to be so large that sometimes can lead to the 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 lack of these it will basically clog the it will clog the toilet. Okay, so the the children will have this history of passing large diameter stools as well. Now, in non-retentive, the clinical manifestations are different. So the children will have socially inappropriate defecation in the absence of organic disease and the absence of excessive stool or fecal retention, and the children will have this symptom duration for at least 2 months, and the symptom frequency will be at least once per month. Diagnosis is to having this soiling of the underwear when the children has been trained and he doesn't have any underlying problems and is greater than 4 years of age. It has a specific pattern, the related factors, the diet history that we already mentioned, and the children might have emotional stress in which the children doesn't want to put perhaps outside of the home because it might have this emotional stress and the associated symptoms that we already talked about. And the physical exam will be to rule out any organic cause. The treatment is behavioral management. So the treatment can include having this scheduled toileting time. You can start retrain the kid toileting sitting at least twice a day if the age is appropriate. Retraining the kid, retrain the kid to gain control over bowel movements, and it is important that the routine can be developed and stick to it. Long-term success depends on how well the person can have this routine set up, and of course prevention of constipation, because if the children has this diet that it doesn't help, like having more fruits and vegetables, more whole grains and breads, the children will have hard stools that it will make him to not wanting to go in and poop. Along with that, exercise helps together with counseling. And this is the conclusion then of this video lecture. Some of you have a good day, have a good night. If you have any questions, feel free to email me, and bye-bye.